Neurology, Ophthalmology, Pupillary Control, Horner Syndrome, Ocular Motility. All right, so for this next page, we're just going to be discussing kind of just the pupillary light reflex as well as a couple syndromes associated with it and ocular motility. So let's start off with meiosis. Meiosis is just constriction of the pupil. It's parasympathetic, and we have this thing known as the pupillary light reflex, which constricts our eyes when light is shined in them. What you need to know is that it sends what goes in the afferent is going to be cranial nerve 2. So the signal that gets sent in is cranial nerve 2, and the signal that gets sent out is cranial nerve 3. Okay, and illumination of one eye results in bilateral pupillary constriction. Okay, so if I shine a light in my right eye, it's going to take it back via cranial nerve 2, and it's going to shoot it back on both sides via cranial nerve 3 and cause constriction of both eyes, even though I'm shining light into only one eye. Okay, it's relatively straightforward. There isn't too much that's confusing about it. Next is the Horner syndrome. Horner syndrome is sympathetic denervation of the face. So you no longer have sympathetic effects occurring at the face. So what happens is you get a classic triad of ptosis, meiosis, and anhidrosis, okay? And so ptosis is going to be the slight drooping of the eyelid, so you don't have the ability to keep your eye open. You have meiosis, which is pupillary constriction, because once again, the pupillary dilation is going to be sympathetically driven. But when you don't have your sympathetic, it's going to lead to meiosis, which is pupillary constriction. And lastly, you have anhidrosis, which is the absence of sweating. Remember, sweating is a sympathetically driven action. So without that sympathetic innervation to the face, we have anhidrosis as well, which is absence of sweating. They love ptosis, meiosis, and anhidrosis in relation to Horner syndrome. It's very, very straightforward. There isn't too much going on with that. Lastly is ocular motility. Ocular motility, what you need to know is that cranial nerve 6 innervates the lateral rectus. Cranial nerve 4 innervates the superior oblique, and cranial nerve 3 innervates the rest of the eye muscles. Now, this is very easy, very straightforward. You have to remember LR6, SO4, R3. All right, if you remember LR6, SO4, then boom, you know that the lateral rectus is done by cranial nerve 6 and that the superior oblique is done by cranial nerve 4, and the rest are very, very easy. Okay, so just keep that in the back of your mind. You should be good for ocular motility. Next, we're going to talk about cranial nerves a little bit more in depth. 3, 4, and 6 are the eyes, right? Those are the ones that we care most about when we're talking about the eye. So the palsies in accordance to the eye cranial nerves are very high yield. The first one being cranial nerve 3. Cranial nerve 3 has 2 distinct actions. It has the motor and parasympathetic components, okay? So what we need to know is that cranial 3 damage presents with essentially a triad. It can be down and out. You get efferent pupillary defect, all right? Because when I shine a light into one of my eyes, the afferent response is going to be cranial nerve 2. But to actually cause the pupils to actually constrict after shining a light in the eye is going to be cranial nerve 3. So when we have cranial nerve 3 damage, you don't have that pupillary response, right? We don't have that pupillary constriction to the light shining. And last one is ptosis. It causes ptosis as well. All right, so those are 3 signs of cranial nerve 3 damage, okay? It presents as a triad. Now, there's multiple things that can cause cranial nerve 3 damage. It could be ischemic. It could be uncal herniation. Remember, we discussed uncal herniation having that cranial nerve 3 palsy. The posterior communicating aneurysm, that can also lead to cranial nerve 3 damage, and that's very, very high yield. So what I want you to know about posterior communicating or the PCOM aneurysm, it can cause down and out, and it could cause a blown pupil, okay? Very straightforward. Cavernous sinus thrombosis and midbrain stroke are other causes. Now, there's 2 aspects, as we discussed already, for cranial nerve 3. There's the motor aspect, and there's the parasympathetic aspect. The motor aspect is going to be more central, okay? So it's going to be the central portion of the cranial nerve is going to carry the motor output. The parasympathetic output is going to be carried in the periphery of the cranial nerve 3. And this is very important because if you have damage to the central portion of the cranial nerve, then you're only going to have specific motor symptoms, right? And if you have only damage to the periphery of the cranial nerve, then you're going to have only parasympathetic symptoms, okay? So let me explain this a little bit further. Let's start off with motor output. So what we said about diabetes, right? So diabetics, they have a issue with their microvasculature. And one of the locations in which we have very, very small vasculature is feeding blood to our nerves, specifically the cranial nerve. So let's talk about cranial nerve 3. So blood that's going to be fed to the inside of the cranial nerves can be clogged by patients that have diabetes or vascular disease, any vascular disease, but diabetes is number 1, okay? So what happens is that it causes nerve ischemia, right? And it affects the inside of the nerve, because ischemia is going to occur first from inside to out, because there's going to be less blood flow on the inside compared to the outside. So it's going to affect the motor output of the cranial nerve 3 compared to the parasympathetic output. And so that means patients that have diabetic mononeuropathy of cranial nerve 3, since it affects only the motor portion, the inside portion, you're going to see signs like ptosis and down and out gaze, so the motor deficits. Whereas on the other hand, for parasympathetic output, let's say we have a posterior communicating aneurysm, it's going to compress the peripheral portion of the cranial nerve 3, and the central portion of cranial nerve 3 will not be affected. So once the periphery is only affected due to compression by an aneurysm, that means the parasympathetic output is going to be affected. Okay? And so that would lead to diminished parasympathetic output, which shows as diminished or absent pupillary light reflexes. It can have a blown pupil, and then you can also see a potential down and out gaze. All right? So keep that in mind. It's going to be parasympathetic versus motor. So whatever's causing your cranial nerve 3 palsy, you have to think, okay, is it causing cranial nerve 3 palsy at the center, or is it causing it at the periphery? Or is it all in all together? Okay? Now, remember, for motor, central, it's usually going to be a diabetes or vascular issue, and it's going to have ptosis and down and out gaze. For the periphery, it's going to cause parasympathetic issues, usually caused by posterior communicating aneurysm, and it's going to be diminished or absent pupillary light reflex with a blown pupil. All right. Next is cranial nerve 4 damage. Very easy and very straightforward. Essentially, what happens is that you have difficulty going downstairs or reading. That's going to be in the presentation of the case. Okay. Now, something that's characteristic is that when you have when you tilt your head to the contralateral or unaffected side, your eyes start to compensate for the lack of intorsion in affected eye. Okay, so the pupil is higher in the affected eye of cranial nerve 4 damage. All right, but remember, you have difficulty going downstairs and reading. Okay, and lastly is cranial nerve 6 damage. This is the affected eye is unable to abduct. Okay, so you can't move that eye towards the out or the lateral side. You can't abduct the affected eye. All right. Lastly, another part of the pupillary, just because we're talking about the pupils, I think it's important to talk about this type of pathology. It's known as anischoria, and that's pupillary asymmetry. And it's caused by a lesion in the oculosympathetic or oculoparasympathetic pathways. Okay, and the defect is usually ipsilateral. So if you ever see someone that has pupillary asymmetry, it's known as anischoria, you could think that the lesion is in the oculosympathetic or oculoparasympathetic pathways, and it will usually be a defect that is ipsilateral. All right. Once again, a lower yield thing. I want you to focus on the cranial nerve 3, 4, and 6 palsies, and you should be good in this understanding. Once again, cranial nerve 3, it has different defects depending on what is defective. If it's the central portion, you're going to have motor deficits, and that's usually caused by diabetes. If you have peripheral compression, usually caused by posterior communicating aneurysm, that's going to have parasympathetic issues. All right, but overall, cranial 3 damage, down and out, efferent, pupillary defect, and ptosis. Okay. All right, that's all.